it's just a tool that helps you function, that compensates for that memory problem. What we're changing is not so much the cognitive skill necessarily, although there probably is some improvement just through practice and through neuroplasticity, but we're really just adapting the environment or adapting the person to deal with their problems, but we're not changing necessarily the cognitive skill. We're not necessarily making attention better or memory better by using these aids. In order to do that, we may want to look at pharmacology. But I will say that when we're talking about pharmacological intervention to change either behavior or cognition after traumatic brain injury, there's one very, very important first step. And I say this all the time, which is to minimize. It's best to minimize the amount of medications you're giving folks with traumatic brain injury than simply always think about adding. And the perfect example of this is really in seizure prevention. So we talked a little bit about this morning, that we know it's a standard of care to not provide routine seizure prophylaxis for late post-traumatic epilepsy. We know that the literature shows that, good double-blind placebo-controlled trials, and as I joked this morning, but it's sort of not so much a joke, that I've been, quote, been known to cure a coma simply by withdrawing phenobarbital. So the most important thing is to withdraw medications that are not needed, and oftentimes that's the best pharmacological tip that I can give you. And if you leave with nothing else today, please leave with that. If we are to give medications, though, that are going to potentially change cognition or to enhance cognition, then we need to have at least a basic understanding of the anatomy of cognition. And Dr. Goldberg talked a little bit about this morning. I'm going to repeat it again today about the prefrontal cortex and the dorsolateral prefrontal cortex and all of the networks that underlie executive functioning and attention and memory and what have you. But we also have to know all the neurotransmitters that are involved in these cognitive functions, how they're formed, how they're inactivated, what are the second messengers that are either activated or deactivated in the course of normal cognitive functioning. As you will find out, the concentration of neurotransmitter within the synapse is a key factor that determines the ultimate performance with regards to a specific cognitive skill. We touched very briefly on some of the genetic influences that can affect recovery after traumatic brain injury. These genetic influences also affect the response to medications, as we'll see. So we'll talk about all of these things in some detail and hopefully leave you with an idea of how best to address pharmacology and cognition. So when we look at traumatic brain injury, we know that we have all of these different ways of damaging the brain through contusions, as we see. Is this a, oh, good, we have a pointer. Okay. Through, is this a pointer? Well, in any event. So we have contusions, we have, and here, of course, if you think about contusions and the whole idea of how the brain is connected, you can have an injury of one part of the brain, but if that area of the brain now is not able to provide input to another area, we can have cognitive dysfunction. Dr. Goldberg talked about the disconnected brain. Again, we're just we're disrupting those axons, that network that connects different areas of the brain so we can do what we do as human beings, be able to think, solve problems, pay attention, and concentrate. We can have extra-axial collections that causes pressure on the brain that impacts areas like the prefrontal cortex and what have you, all impacting negatively cognitive skills. So you can take a look at all of the different brain areas that can be affected by traumatic brain injury, the normal functions that they subserve, and you can see that there's going to be cognitive problems as a result of that injury. So let's start off with some neuroanatomy. I know it's a little tough after lunch and you're a little tired, and we talk about the exciting topic of neuroanatomy. So executive skills and working memory. Predominantly, these skills are subserved by networks that live here in the prefrontal cortex. These functions, these executive functions, are modulated predominantly by noradrenaline and dopamine, and of course glutamate, which is the most ubiquitous neurotransmitter in the central nervous system, will modify the actions of both noradrenaline and dopamine. We can get a little bit more specific and look at executive skills as well as some spatial and conceptual reasoning that lives over here in the dorsolateral prefrontal cortex. And again, it just shows that these are where these functions are predominantly located. But then we take a look at the neuroanatomy of norepinephrine, and the cell bodies that contain norepinephrine predominantly live here in the locus ceruleus, but look at where they project. Well into the neocortex and the cingulate cortex. This is where a lot of these functions live. They project to the prefrontal cortex, so we know that executive functioning and the like, working memory, to some degree, are going to be impacted by norepinephrine. The same thing can also be said of dopamine. As Dr. Goldberg said this morning, the dopamine-containing neurons that we're concerned about in cognition, at least, live in the ventral tegmental area, and they project rather widely also to the prefrontal cortex. So again, dopamine, as you can see from this slide, is going to be intimately involved in executive functioning. Dr. Goldberg talked about that very eloquently today. And you can see that these are long projection fibers that are very susceptible to diffuse axonal injury. Just look how long they are. So it's very likely, as these axons are stretched, we're going to get dopaminergic impairment or dopaminergic deficits in the frontal cortex, just where we need it to improve cognition. If we take a look at attention, attention is probably even more widely dispersed, or the network is more widely dispersed, partly because attention is really so complicated. It's not just simply paying attention, it's divided attention, sustained attention, susceptibility to distractibility, and what have you. We do know that this attention network, which includes everything that we have here on this slide, is mediated by catecholaminergic pathways, as well as acetylcholinergic pathways. I think we always think of attention as more noradrenaline and what have you, but there's a very heavy component of acetylcholine as well, as we'll see. So once again, we have the locus ceruleus, but also, besides projecting just to the neocortex and to the prefrontal cortex, there's a fair amount of projection, well, actually with attention, we'll get to memory in a moment. All of these areas here, which these hours should be going up there as well, are going to subserve attention. But equally important is acetylcholine, and we look down here, the nucleus basalis of Maynard, and of course, look at the location. This is where we have the areas of contusions, inferior frontal lobe. So you can well imagine that the nucleus basalis of Maynard can easily be injured because of frontal lobe contusions, and all of these projections to the cortex, acetylcholinergic projections to the cortex, which help to subserve attention, will be lost, also through the process of diffuse axonal injury. And as I said before, attention is a much more complex function than I think most realize, but for all the psychologists in the room, you already know this, so I think I'm preaching to the choir. Memory also a very complex process that when you start to think about how complex it is, it involves the acquisition of the memory, consolidating it, and then retrieving it. And we think of acetylcholine as being the primary neurotransmitter involved in memory function, and it certainly is extremely important, as we'll see. But also, there's a very strong catecholaminergic component to this as well, and we'll see that again in the slides. In the anatomy, rather. Memory subserved certainly by the hippocampus, as I think we all realize, but also the amygdala. And it's probably worth mentioning here that so many of the cognitive processes that we rely on are really all interrelated. It's very hard to remember something if you don't attend to it in the first place. And it's almost impossible to have working memory if you weren't able to pay attention to the information that you needed to learn to make working memory occur. So all of these processes are really interrelated. Again, we have the nucleus basalis of Maynard, lots of projections to the hippocampus. Again, this is why it's so involved in memory. But also, again, norepinephrine, as we can see, lots of projections from the locus coeruleus down to the amygdala and hippocampus. And in fact, there are beta receptors in the hippocampus, and these are important for normal memory function. So let's just take a look at some of the basic physics. This is a very simple slide. I made it myself, which is why it's so simple. This is how I understand it, at least. This is just an indication of all the different areas in which, if we are to provide pharmacology where we can act on it, we can increase release of norepinephrine or whatever neurotransmitter we're talking about to increase synaptic levels. The amount of norepinephrine, there we go, is modified by either reuptake, active reuptake back into the presynaptic membrane. We have a negative feedback mechanism here with presynaptic alpha-2 stimulation. We can also deactivate norepinephrine by catechol-O-methyltransferase, COMT. And I'm going to ask you to remember this because the amount of COMT, which is genetically determined, will ultimately determine how much norepinephrine we have, and dopamine for that matter as well, in the synapse. Monoamine oxidase also inactivates norepinephrine in the CNS. Of course, we can also provide direct chemicals that perhaps stimulate any of these postsynaptic membranes as well, which will then, of course, alter cognition by acting on some of these second messengers. So why would we want to use norepinephrine agonists to improve cognition? Well, again, this whole idea of this disconnection or dieschesis, you can have an intact neural structure, so the prefrontal cortex can be completely structurally intact, yet it lacks the input because of diffuse axonal injury. It's lost input from the locus coeruleus. It's been shown over and over again that amphetamines can enhance metabolic activity in regions adjacent to injured cortex. And we also know that amphetamines enhance the process of long-term potentiation. And actually, they also have been shown to be involved in the treatment of depression. For what it's worth, sad people do not do as well in rehab as happy people. Seems rather basic, but it's really true. We also know that stimulants like methylphenidate or dextroamphetamine can enhance synaptogenesis. And again, we're talking connectivity. So the more synaptic connections we're making, the more the brain is connected. By and large, and it's a bit of an overstatement, the more we can actually achieve with regards to cognition. We also know that depressing the brain through different inhibitors like GABA agonist, we can actually inhibit plasticity and may slow down recovery. And I think it's important to know that this whole idea of neurogenesis and plasticity is something that goes on through adulthood. You know, when I was in medical school, and I joked before in the Middle Ages, you know, we were taught that, you know, the brain is the brain, and if you lose a nerve cell, boy, that's it. But we know that neurogenesis and synaptogenesis and plasticity occurs throughout our life, and we certainly want to enhance that following injury to the brain. There are a bunch of noradrenergic agents that we can use. Methylphenidate, probably the one that's been around the longest, as well as a whole host of others here, and we'll talk about each one of them separately. Okay. All right, so methylphenidate, this increases synaptic concentrations of both dopamine and noradrenaline by blocking its reuptake. It has a fairly fast mechanism of action, so within 30, 60 minutes you get really peak serum concentrations, and it doesn't stay in your system for a very long period of time with a half-life of about 2 hours or so. And in the United States, we have this medical journal called the Wall Street Journal and the New York Times. I joke a little bit, but we oftentimes hear these negative stories about the problems with methylphenidate and how it's overprescribed. I will tell you that in my experience, it is a very well and very easily tolerated drug. I just have the circle here showing where methylphenidate's mechanism of action is. It basically is preventing or blocks reuptake, so it increases the concentration of synaptic norepinephrine. Probably the biggest area in which methylphenidate has been shown to be effective, certainly in children with attention deficit disorder, but also in traumatic brain injury, is in the realm of attention. It's also been studied in memory, of course, sort of makes sense because there are beta receptors on both the amygdala and the hippocampus, and we'll also take a look at its effect on motor speed. With regards to vigilance and sustained attention, there are several studies, and I have the references there, and I think this is also in your handout, so you don't have to worry about, I sent a handout, hopefully you folks got them. Lots of blank stares, maybe you didn't, but in any event, methylphenidate has been shown to either improve or tends to improve both vigilance and sustained attention after traumatic brain injury, and these studies are all on studies of folks with brain injury, so it looks like it's pretty effective there. It also seems to be very likely to improve processing speed. And processing speed is always one of those functions in the neuropsychological test reports that I read, at least from our psychologists at Rusk, is almost always impaired in folks with traumatic brain injury. It's one of the most common ones. Distractibility, evidence isn't really quite there with regards to methylphenidate's effect on decreasing distractibility, but that may be just due to the way the studies were designed. So it probably works, but the literature as yet does not support it very much. There are some studies that show that methylphenidate may improve memory, but it really tended to vary from subject to subject, and the evidence here wasn't strong. And the question is, of course, we know that the amygdala and the hippocampus has beta receptors, and we also know that giving beta blockers, a typical set of drugs that we use to treat high blood pressure, can impair memory in people who already have impaired memory, not in normal subjects with normal memory, but in folks with impaired memory. So we have to be a little bit careful in providing beta blockers in some of our folks with traumatic brain injury. But the question I also ask in looking at some of these studies is, was the improvement in memory, that of course varied from subject to subject, due to a direct beta agonism on the hippocampus and what have you, or was it that just attention was better? Remember, you can remember something a little bit better if you attended to it better in the first place. So that's my question with these studies. And I guess here again, I just remind me, I guess I was like Dr. Goldberg, I'm getting ahead of my slides with regards to telling you about beta stimulation. And again, beta blockade in memory, potentially problematic in folks who have pre-existing memory impairment. So a lot of this also has to do with the type of beta blocker that's being used. If you have a lipophilic or fat-loving beta blocker that sneaks into the, or bypasses, or passes through, I should say, the blood-brain barrier, you may get more of these central nervous system side effects as opposed to beta blockers that are hydrophilic and don't get into the central nervous system quite so much. With regards to motor speed, and this has actually been shown pretty much over and over again, methylphenidate seems to have no impact on motor speed. Its impact is more on the cognitive or mental realm and not so much at all on the motor realm at all. Dextroamphetamine, slightly different noradrenergic agonist or catecholaminergic agonist. Its predominant mechanism of action is a presynaptic release of biogenic amines, and it's really throughout the brain. Also fast-acting, but it has a little bit of a longer half-life, up to about 10 hours, so we have to make sure that we're not giving it to our patients late in the day, otherwise we'll keep them up. This is also safe in my experience, a slightly higher incidence of mostly cardiac heart rate side effects, but also pretty well tolerated, at least in my experience. The mechanism here in my little circle is enhanced release of catecholamines into the central nervous system, and it's really rather widespread, I would say. Atomoxetine is also another catecholaminergic agonist. It's presumed to inhibit norepinephrine reuptake, and its site of action, at least in attention deficit disorder, is in the prefrontal cortex, which of course, as we know, is so important in executive functioning. And again, here, this is just the circle showing its mechanism of action. Modafinil, which has been around now for a while, it's a drug that's actually approved for the treatment of narcolepsy. But it is a stimulant medication, and its stimulating properties are different from methylphenidate and dextroamphetamine. There's still some debate about exactly how it works. We do know that it's less addictive than either methylphenidate or dextroamphetamine, and it's very well tolerated with regards to pulse, heart rate, and what have you, and blood pressure. It's been shown, at least in animal studies, to increase a whole host of neurotransmitters in the synapse: norepinephrine, dopamine, serotonin, glutamate, and what have you. So it has a rather ubiquitous effect. As I said, it's approved for the treatment of narcolepsy, and interestingly, it's been shown to help reduce fatigue in a number of neurological conditions. Studies support its use in multiple sclerosis, Parkinson's disease, obstructive sleep apnea. But what is disappointing is that recent studies that have come out have shown that it is not so effective in reducing fatigue after traumatic brain injury. And fatigue, as it turns out, is a big problem in TBI. One of the most common complaints you'll get is debilitating fatigue during the day, or what I call excessive daytime somnolence. We all feel tired, especially when we're jet lagged, but unfortunately, so far it would appear that modafinil is not well supported with regards to decreasing feelings of fatigue after traumatic brain injury. And this I already mentioned. Guanfacine, this is one of the few receptor-specific drugs that are available, commercially at least. This is an alpha-2 receptor agonist. If you recall, there's an alpha-2 presynaptic receptor that provides a negative feedback loop, but what we're particularly interested is in the postsynaptic activity of noradrenaline, particularly in the frontal cortex, and I will tell you that just the right concentration of noradrenaline in the prefrontal cortex is important, because you'll get preferential activation of the alpha-2 receptors. If you have actually excessive stimulation through excessive noradrenaline in the prefrontal cortex that occur, let's say, during times of stress, you actually have a decrement in cognitive performance. But at least with guanfacine, it's such as a specific alpha-2 receptor, it may actually avoid that potential complication. And here again, I have the circle, just to give you the visual of where its mechanism of action is. So in general, catecholaminergic agonism seems to improve a bunch of cognitive functions through all these drugs that we have up here. Bromocriptine actually is a dopaminergic agonist. We'll get to that in a moment. And it may do this actually by improving the efficiency of cognitive processes. Here and in this study, individuals were provided either placebo or methylphenidate, and what was shown is an improvement in their cognitive performance. It was also associated with a decreased blood flow to that area. It almost seems counterintuitive, but the authors of this particular study, the researchers, felt that the decrease in cerebral blood flow represented an improved efficiency of these frontal lobe tasks when they were given the methylphenidate. So that may be one mechanism by which it works. All right, let's go on to dopamine, also a catecholaminergic agent. Again, the cell bodies that we're concerned about that contain dopamine with regards to cognition live in the ventral tegmental area with wide projections to the frontal cortex and, of course, the prefrontal cortex that we're so concerned about with regards to executive skills. Sort of a simple slide here for dopamine. And what we're really concerned about is the mesocortical system, because these are the projections from the ventral tegmental area to the prefrontal cortex. There's also the mesolimbic system that projects to the limbic system, and of course is involved in psychiatric disorders. So with regards to the mesocortical system, with its projections to the frontal cortex, it's going to have an impact on attention and executive skills, as you can well imagine. So in traumatic brain injury, what's our rationale, if you will, for using dopaminergic agonists? Well, there's fairly good evidence to suggest that there's actually a dopamine deficiency after traumatic brain injury, and this has been shown by a number of studies. So if it's lacking, give it to them. Lots of drugs that we can use to enhance dopaminergic function after traumatic brain injury, and they're all listed here. I would say that in the United States, we probably use more amantadine and bromocriptine than anything else. I think that's just where a lot of the evidence lies, which, by the way, is not that great, but it is there. Ooh, baby. There we go. But one thing I'm really interested in is in looking at the catecholamine O-methyltransferase inhibitors, because I think we're going to be seeing a lot more of these in the future with regards to TBI. So what does some of the evidence show? Amantadine. Amantadine widely increases dopamine throughout the CNS, and in human studies has been shown to improve function after traumatic brain injury in a number of small trials. This is one that was done by John White, one of the leading researchers in America, and it appeared to improve the disability rating scale. That's what I talked about this morning, if you recall, in a multi-center trial. There's also an ongoing multi-center international trial looking at the effectiveness of amantadine in improving arousal early on after traumatic brain injury. Joe Giacino, who was at JFK and just recently moved up to Harvard, is looking at amantadine in a double-blinded, placebo-controlled manner to see if it improves arousal from either the vegetative state or the minimally conscious state after a traumatic brain injury. And it's a study that's been going on for several years, which just speaks to the challenges we have in rehab medicine in getting good trials done. Once this is completed, and hopefully we'll get some positive findings, it'll be one of only a handful of studies that have really looked at many patients in a drug trial. So I'm definitely looking forward to getting these results. But the trial is still ongoing for a long time. How amantadine may work. In this particular study, published several years ago, amantadine was shown to improve executive skills, and those improved executive skills were in fact associated with increased glucose metabolism in the prefrontal cortex, as you can see here in this slide. Other studies looking at amantadine include this one trial that was done by Jay Maythal, where he was still down at Alabama. What he did was took a number of individuals with traumatic brain injury who came into his center, and in a placebo crossover trial, gave half of them amantadine early on, and gave the other half amantadine a little bit later on. And what he found was that the folks who got the amantadine early tended to do better with regards to faster improvement in their cognitive status, and that was measured by the mini mental status examination. Their FIM scores. FIM is, I'm not sure if you use it here, but that's the functional independence measure, and he looked at the cognitive subscores, and those tended to get better faster. Their GOS tended to improve at a faster rate than those who got the placebo first, as well as the disability rating scale. The folks who got the amantadine later on caught up with these folks, and although this didn't reach statistical significance, it fell victim to what normally happens in a lot of these studies. There just wasn't enough of a population to reach significance. So I believe that it probably would have had he had more than the 20 or 30 patients that were enrolled. Now, I always like to say, sertraline was not approved as an antidepressant because 20 people participated in the study. It's more like, 2,000. That's really what we need to do in rehab medicine, is get more of these multi-center studies going. There's a little bit of evidence to suggest that dopaminergic agonists, particularly bromocriptine, may help to improve attention with regards to specifically hemispatial neglect. I will say, however, that the studies here are really rather mixed. There's some evidence that it really did help. There are some evidence that it actually made attention worse. In the one study, and I think I have it there, denoted by an asterisk, where hemispatial neglect after stroke worsened with dopaminergic agonism. The authors speculated that perhaps the medication made attention to the involved hemisphere so much better that it seemed to be a relative decreased attention to the uninvolved hemisphere. It was more of a speculation on their part, but sort of an interesting one at that. Other potential effects of dopamine include improving initiation and motivation. I touched base on this a little bit this morning when I was talking about apathy and the akinetic mute state in my apathetic dog, who's anything but apathetic. Some very mixed results regarding the effects of dopaminergic agonism on language function. Some say it helps, some say it doesn't. With regards to language function, you may be familiar with some of these studies. Dopaminergic agonists like bromocriptine being given in folks with aphasia. In the studies, at least in my read of the studies that show that it was a little helpful, it's more and more like the in the transcortical motor aphasias, where folks are non-fluent but certainly have the capacity to understand and repeat. Those are the folks that tended to get a little bit better. It was in the more global aphasias or severe aphasias where these dopaminergic agonists did not seem to have much of an impact. Now, who benefits from all of these medications? Is it those with poorer baseline skills or better baseline skills? Does genotypes or phenotypes have any impact to it? And of course, the answer to that is, it probably does. So what we have here is what we call the inverted U-shaped graph. And if you think of increasing synaptic levels of neurotransmitters along this axis and increasing cognitive performance along this axis, there is a certain range, an optimal range of neurotransmitter in the synapse that correlates with optimal cognitive performance. So either too little or too much of a certain neurotransmitter will have a negative impact on your cognitive performance. So I will often use this graph when my residents say, shouldn't I be taking methylphenidate before my board examination? Of course, the answer is no. You're already performing at optimal performance. If you take methylphenidate, your norepinephrine and dopamine will go way up and you'll do worse on your exam. Sounds good, at least. And your synaptic concentration of neurotransmitter, particularly, and I'm going to just use an example, dopamine and noradrenaline, is in fact at least partially determined by your genetics. So as you mentioned as you saw earlier, several times, the physiology of dopamine and noradrenaline, catechol-methyltransferase, or COMT, inactivates synaptic concentrations of these catecholamines. And the amount of COMT that any one person has is at least in part determined by your genotype. So the more what I call Val alleles you have, the more COMT activity you have, and therefore the less synaptic noradrenaline and dopamine that you'll have. And we know that folks with the Val allele tend to have poorer baseline performance on various cognitive tests like working memory, and this is true of both healthy controls and individuals with traumatic brain injury. And it's these people, those with either poorer baseline activity or those who have this Val allele tend to be more responsive in a favorable way to catecholinergic agonism. So these folks tend to do better when we give them bromocriptine, amantadine, or what have you on various cognitive tests. And this is actually important because, as it turns out, there are many different ways of, as you know, of deactivating or decreasing catecholinergic activity in the synapse. There's enzymatic degradation, there's active reuptake, as we mentioned, but in the prefrontal cortex, the primary mechanism of deactivating or decreasing levels of dopamine and noradrenaline is, in fact, COMT. And, of course, the prefrontal cortex is where a lot of these cognitive processes live. So COMT or drugs that potentially may impact COMT may have a big impact on cognitive performance. Here, this is a study looking at individuals with schizophrenia, their unaffected siblings, and normal controls. But I think what's important is that their performance on a test of frontal lobe executive skills, here the Wisconsin card sorting test, individuals, regardless of their grouping, performed worse if they had both the val-val alleles and performed better when they had only met alleles. Again, it would seem that genotype will impact your overall cognitive performance. Now, as it turns out, I gave this talk just several weeks ago for the first time, and I came across a study from Germany that showed that individuals with the val-val genotype, whereas they may not be as good at some of these frontal lobe functions, they seem to be better at making very quick decisions and making quick, accurate decisions, and that apparently is a good trait if you're a stock trader. So I guess if you have the val-val genotype, you're better at the stock market. So if anybody knows their genotype out there and you're the val-val, I want to talk to you for some stock recommendations before you leave, and that is a requirement. There's also some evidence, as I said before, that your baseline performance on a particular cognitive test may also determine how well you may perform on a particular drug. So in this study, and this is in healthy controls, there was a sum of z-scores on frontal lobe tests, and actually the lower the z-score in this particular example, the better your cognitive skill was. And on placebo treatment, you see two different baseline performances. These are the folks who did well at baseline. These are the folks who did less well at baseline. Give them bromocriptine, which is a specific D2 receptor agonist, and the folks who did badly got better, and the folks who did well got worse. So again, this goes back to that inverted U-shaped curve, that there is an optimal level of synaptic neurotransmitter that corresponds to optimal cognitive performance. Now, of course, in traumatic brain injury, we presume that there is this decrement in dopamine, which is why we think our patients benefit from them. Again, we're giving them what they need. Let's go on to acetylcholine. Again, just repetition is a good thing. Acetylcholine lives in cells throughout the central nervous system. We're predominantly concerned with regards to cognition here in the nucleus basalis of Mazert, which is projections throughout the neocortex as well as the hippocampus. This is why it's involved in both attention and memory function. So why would we want to use drugs that enhance acetylcholine following traumatic brain injury? And here we really do rely on evidence from other conditions, particularly Alzheimer's disease. We do know that acetylcholine is an important component in normal memory and learning. I think most of us know that. We know that there's an cholinergic deficit, if you will, in Alzheimer's disease and other dementias. And in the past, we've known that drugs that enhance acetylcholine activity, like physostigmine or lecithin, which is a precursor, tends to improve cognitive functioning in some of these conditions. So if it works there, maybe it should work in traumatic brain injury as well. And in fact, it probably does, although I just want to start off by saying that a lot of the improvements that we've seen with the acetylcholinesterase inhibitors like donepezil have been modest at best, modest just like it's been modest in Alzheimer's disease. But there are several small studies and case reports in which donepezil has been shown to improve memory and cognition, maybe even mood, following traumatic brain injury, and there's a whole host of them listed there. These were actually, some of them are very small, some of them are even just a single case report. I will say that there was a fairly, we just might as well put it down there, one of the very few good studies done in rehab medicine looking at rivastigmine with regards to its impact on cognitive functioning after traumatic brain injury. Interestingly, the original thought when we first started using some of these acetylcholinesterase inhibitors in TBI is that we felt that oftentimes not oftentimes, because traumatic brain injury is not a progressive disorder, that if we were to give these medications to improve function, it would actually have a more beneficial effect than it would have in Alzheimer's disease, let's say, which is a progressive deterioration. But as it turns out, what we found in a multi-center trial, and actually I did participate in this one, was that Exelon actually improved memory only in those who had a severe memory impairment. Those who had only a mild or moderate impairment did not improve. And actually, in retrospect now, when we look at that inverted U-shaped curve, sure, that sort of makes sense. If your baseline is closer to optimal functioning, you're much less likely to benefit from the medication as opposed to being to the left of that curve, whereas you really need the acetylcholine. This is one of the few, and I will tell you, it took it was either 12 or 16 centers to get 150 or 160 patients into this trial. That's the type of work it takes to get a good trial going in rehab medicine. It can't be done in one or two centers. It has to be multi-center. Now, nicotine has also been found. Nicotine is a potent acetylcholinergic agonist, acts on nicotinic receptors, which are acetylcholinergic, as you undoubtedly know. And there's some evidence in folks with senile dementia that the nicotine patch was effective in improving attention. Now, I just need to tell you, I am not recommending anyone in this room to smoke. I will be kicked out of the AMA. But it also helps to explain why folks who quit smoking sometimes are a little cognitively discombobulated, as we like to say. They're missing that acetylcholinergic burst. So in summary, what do we do with regards to pharmacology of cognition? First thing to do is minimize, avoid the neuroleptics, particularly the older ones, the haloperidols, the melarils. I will tell you that many of the antiemetics are actually neuroleptics in disguise. Compazine is a neuroleptic and it can impair cognition. The best you can, avoid the centrally acting antihypertensives. We didn't talk too much about it. GABA agonists, I know baclofen is one of them, but be careful about that. It has been shown to impair recovery, certainly in animal models, and be wary of phenobarbital, or you can be famous too by stopping phenobarbital, and you can, say that you cure coma. And I would urge the judicious use of various noradrenergic, dopaminergic, or acetylcholinergic agonists to help the cognitive performance of your patients. Some limitations. There is a profound lack of good double-blinded, placebo-controlled Class 1 studies. There are multiple factors that influence drug effects that you need to keep in mind, and there are very few receptor-specific drugs. So in the animal models, where we can target alpha-1, alpha-2, beta-1, beta-2 receptors, and D1, D2, and so forth and so on, that specificity is lacking in commercially available drugs, so just keep that in mind as well. Despite that, there are some guidelines that have recently been published with regards to medication. Lots of options, but these are the recommendations that came at a guideline level. Notice, please, that these are not standards of care because the literature does not support any standards of care. But for the performance of executive skills, bromocriptine and D2 receptor agonist seems to be effective in severe TBI for improving executive skills. The acetylcholinesterase inhibitors, again, improving memory in severe TBI, and both methylphenidate and the acetylcholinesterase inhibitors to improve attention following moderate to severe traumatic brain injury. Now, let me just end off by giving Flanagan's guidelines for what it's worth. If you do choose to give medications to improve cognition, my recommendation is to start at the low dose and then increase that dose very slowly. The idea, obviously, is to use the lowest dose of a medication that results in whatever the desired effect you're looking for, and it will require ongoing assessment not only of yourself, but of questioning family members and therapists to determine if that effect has been achieved. I also recommend only giving one medication to improve cognition or behavior at a time. Once you start trying to induce polypharmacy all at once, you really have no idea what medication is having what effect. It becomes very difficult. At some point, if your medication has worked, you're going to have to ask the question, does my patient still need it? So it is wise to periodically withdraw these medications, and it's really done on a case-by-case basis to really make some assessment of whether someone still needs it. And I need to just let you know, certainly in the United States, that the use of all of these medications, every single one that I mentioned to you today, remains off-label. The FDA in America has not approved the use of these medications for these purposes, so they're all off-label use because the studies, unfortunately, just haven't been there to support their use. And yes, that's my famous dog. She's now famous in Greece. Okay, so I think we have a few minutes for questions before we go on to Dr. North's presentation. Yes? About guanfacine? Yeah. It's mostly clonidine. It's really predominantly clonidine has been, we used to use that actually as a means to help decrease spasticity after a brain injury. Guanfacine is not well studied in traumatic brain injury. I put it there just for information regarding a mechanism by which it may actually help to improve, but it's really not well studied. So there's no evidence looking at guanfacine as yet in TBI or stroke or any type of brain injury.
It's about amantadine, because amantadine is a relatively dirty drug.
Yes.
In addition to dopamine, we have an MDA. So I would like to know how much do you think of the effects that you've told us that are positive are due to dopamine agonist effects?
Yeah, by and large, it's interesting, and I get this question a lot. For whatever reason, and I'm not quite sure if it's because it's an inexpensive drug or it's been around for a while or why it's used, but it's the drug my colleagues in America like to use more than almost anything else, including bromocriptine, saligeline, levodopa, and what have you. It is a dirty drug, and it actually it's dirty in so many ways. It also just impacts really the whole brain. I guess the feeling is that there really is a widespread dopaminergic deficiency in traumatic brain injury, and right now the evidence. There's more evidence, although it's really sort of class 3 evidence, to be honest with you, that it is effective. So that's really the best explanation I can give you. It's just what we use. Oftentimes I'll speak to neurologists about this and why don't you use some of the more specific ones? And they're coming out now with more specific dopamine receptor agonists, and I think that again we'll just have to wait for the studies to come out. But at least in America, drugs that have been around a while that are off-label are really inexpensive.
Regarding the psychostimulants and the atomoxetine, I understand that we have to titrate the doses, but what is your personal experience? Do they usually respond to low doses or to high doses? I'd say
my own personal experience is that I don't use atomoxetine very much. I use predominantly methylphenidate. It's just a personal choice. It's been around for a long time, and in my experience, it really is pretty darn effective and very well tolerated with a very short half-life. And again, because it's available in generic for some of my folks who don't have great insurance coverage, it's easily affordable. But with methylphenidate, at least, I will say that I always start out at a very low dose, 5 milligrams twice a day, in the morning, in the afternoon. I tend to be a little bit more conservative than many of my colleagues, and I'll go as high as 15 milligrams twice a day, rarely up to 20. I have one patient actually on 25. But if I'm not seeing a desired effect by the time I get up to 20 or 30 milligrams a day, it's unlikely that I'm going to see an effect at 40 or 50 milligrams. So, but that's also one of the drugs that after a period of time I will tend to try to withdraw just to make sure to see if someone still needs it. And actually my experience is that they tend to continue to require it.
Could we use this kind of medication to help children with retardation, Down syndrome, learning difficulties? I mean, is it also effective for children who are developing and have difficulties in performance?
Well, certainly methylphenidate is approved for children with attention ADHD, attention deficit hyperactivity disorder. I don't myself treat folks with either mental retardation or Down syndrome, so I'm not really familiar with their effects in there. But children with traumatic brain injury or adolescents with traumatic brain injury, I will say absolutely we use them.
We had some hearings about DOPA on the coma.
DOPA on the coma.
Yes.
Right. So so again, why evidence regarding dopaminergic agonism and increasing arousal and motivation and initiation have been around, for decades. There are a number of case reports in the literature and small case series.
Some case reports.
That in some of these low-level patients, either in the vegetative state or minimally conscious state, when given amantadine, have perked up and have woken up a little bit. And I have to say, that in my own experience as well, I provide some consultations in some nursing homes, and when one person in the nursing home gets the flu, the internist taking care of those nursing home patients put everybody on amantadine, the idea that it has some antiviral activity. And that's when everyone seems to wake up a little bit, and of course everyone starts falling out of bed because they're getting a little bit more, I won't say agitated, but more mobile. And I think because it's so widely distributed, perhaps that's why it works. But again, but it has not been put to the true scientific test until now in this multi-center trial.
And speaking about anecdotal case reports, in aphasia case, we have I have in mind two publications about zolpidem and benzodiazepines. I mean, this is more paradox, more...
Yeah. Right, so it is quite a paradox. I think what you're referring to...
Suppressing the other side, something like
exactly.
that.
So, and I'll just give you my take on that. So, there's reports in the literature of zolpidem, a sleeping pill, actually waking people up after brain injuries of what have you. And it seems, that's so paradoxical. How can a sleeping pill actually wake you up? But zolpidem, like all of the Z drugs, zolpidem, zolpican, and I forget all the generic names of the rest of them, do act on benzodiazepine receptors. And we also know that there are some folks who have the paradoxical reaction to the benzodiazepines rather than being anxiolytic. It actually wakes them up. So it's my theory. I don't know what my colleagues think, that it's sort of the same principle. Whatever that paradoxical reaction is to benzodiazepines may underline that paradoxical reaction to zolpidem as well. Flanagan's thoughts.
We go on.
Thank you very much.